Grazie, buongiorno a tutti. Allora, good afternoon to everybody. And maybe I just start quickly with announcing the speaker. Actually, first, I would like to, I was advised to mention a couple of sad things. I just learned that last week Masasu Mimura just passed away because of lung disease, and so I think he contributed a lot to mathematical biology, and I thought it was appropriate remembering him. And unfortunately, just this happened at the end of the year, but unfortunately I learned that only recently, that also Nick Britton died at the end of 2020, and he was a main contributor to mathematical biology. And I think we all will miss his presence and his also very nice, important, nice contributions. And so I thought it was useful to say that. And after this, I don't know, unfortunate contribution, I'm happy to introduce Laura Di Domenico. Laura is currently a PhD student at INSERM and the Université de Paris Sorbonne, and she's, I mean, of course, fortunately for her, she's still very young, but has already some contribution as a first authors to papers appeared this year, and also contribution in Nature. And so I please her. And she was, before going to Paris, she was a master's student at the University of Trento. So we are pleased to say that, and happy to give her the floor.
Thank you. Thank you for the introduction. It's a pleasure for me to be back at the University of Trento in such a great venue inside this seminar series. Thank you for the audience for joining this session today. Let me start with a brief introduction of the epidemic evolution in France over the last year. So the COVID-19 pandemic in France has followed a similar pattern as the one observed in Italy. This is the number of daily hospital admissions due to COVID-19 over time during the last year. And you can clearly see the first wave in March and a second wave in November. In response to the increasing epidemic activity, the French authorities implemented 2 national lockdowns. A first lockdown with the strict stay-at-home orders, school closed, and all non-essential activities closed. And the second lockdown, which was milder, schools remained opened, and a larger fraction of professional sectors were allowed to operate. Besides the lockdowns, which of course are an example of an extreme intervention, today I would like to focus more on the control measures implemented between epidemic waves. So in a situation in which there is no evident and clear resurgence of cases. First of all, I will present you a work that we performed last summer, quantifying the underdetection of cases in the period exiting from the first lockdown. And the last part of my talk will deal with the impact of curfew measures implemented at the beginning of 2021 in response to the emergence of more transmissible variants in the country. So let me start with the underdetection of cases. Why did we choose the period of May-June to study this? Because this period, after exiting the first lockdown, was supposed to be the period in which the test, trace, and isolate strategy was expected to effectively trace and identify and isolate the majority of cases. So the first thing that we did was to look at the virological data. So in the light of lifting the first lockdown, a new testing system was created in France, and this involved recommendation to the population to go and see a doctor in case of suspect COVID-19 compatible symptoms, to go to see the doctor and to get a prescription to get tested. So obtaining a prescription from the doctor was mandatory in order to get access to a test. Moreover, a centralized database was put in place in order to collect all virological data at the national level. This database included highly detailed information on date, location, and outcome of the test, but also information about the presence or absence of symptoms at the time of test. So we wanted to have an idea of the number of symptomatic cases that were detected by the system. We realized that we couldn't only rely on the cases that showed symptoms at the time of test, because indeed people without symptoms at the time of test could either be true asymptomatic or pre-symptomatic, so in the prodromic phase before the onset of symptoms. This was because indeed this database was not supposed to collect follow-up data on the individual, so we couldn't know if an individual would develop symptoms after the test. So we took that into account, and then we also used another information provided by the database, which was the onset to test delay, which was self-declared by the patient at the moment of the test. And you can see this information summarized in the figure on your right. So actually the delay from onset to test decreased over time, suggesting that the system was becoming faster in identifying the cases. So we used this information to estimate an onset date for the cases that were tested and considered as symptomatics. So after that imputation, we were able to provide an estimate of the number of symptomatic cases, and that would be the orange bars in the plot on your left, that sum up to more or less 14,000 cases detected by the system in the study period considered, which ranged from May 11, the day on which the lockdown was lifted, to the end of June. Now, this is the number of cases detected by the system, but what about the real number of cases? So, of course, to estimate that, we used a mathematical model. The mathematical model is a compartmental model, which is a generalization of the classic SEIR model. So it takes into account a latency phase in which individuals are infected but not infectious yet. It takes into account pre-symptomatic transmission. And at the end of the prodromic phase, an individual may either remain asymptomatic or develop symptoms. And symptoms were divided according to symptom severity, ranging from paucisymptomatic individuals to individuals with mild or severe symptoms requiring hospitalization. The probability of developing a certain degree of symptom is actually age dependent, because the model also accounts for an age structure differentiating between younger children going to pre and primary schools, teenagers going to middle and high schools, adults and seniors. The model also integrates data on the demography at the regional level, because we used a specific model for each French region. And then the last ingredient of the model is the contact matrix, which drives the mixing among age classes inside the population. For the contact matrix, we used data collected from a large-scale survey conducted in France as an empirical contact matrix, describing the mixing in normal conditions, so in pre-pandemic condition, let's say. And of course, we realized that these metrics could not be the perfect metrics to correctly describe the situation in which there is a measure which is implemented. So what we did is that we took these empirical metrics and we modified the metrics according to some rules in order to obtain a synthetic matrix that could better reproduce the mixing in presence of some interventions. How did we inform this modification of the matrix? We looked at different sources of behavioral data. So the first source that I can present to you is the presence at workplace. So we looked at Google mobility trends to see the variation in the number of people at workplaces. This data come from location history data collected from mobile phones. And we use this information as a proxy for the percentage of people going to work, and the percentage of people performing telework. As you can see, starting from mid-May to the end of June, there was a rebound in the number of people going back to work. Then we also looked at schools. So after the first lockdown, during which schools were closed, schools were reopened on a voluntary basis. So this produced a large heterogeneity in the percentage of students attending schools within the country. And we took this data from the Ministry of Education. And then we also looked at some other behavioral data, in particular, the information about adoption of physical distance. So we, from a survey conducted in France, we knew that actually, while exiting the lockdown, people were gradually regaining physical contacts. So the percentage of people avoiding physical contact decreased over time. But indeed, we found that seniors were the ones which kept physical distance more with respect to the other age classes, suggesting indeed an effect of increased risk aversion in seniors with respect to the other age classes. So how did we integrate all these data inside the parameterization of the contact metrics? So the data about the context we had were highly detailed and included information on the location in which the contact was engaged, and also the type of contacts, so whether it was a physical or non-physical contact. So since we had this information about the location, we could act on the contacts according to the location. So for example, in order to reproduce a matrix which simulates lockdown, we remove the contacts associated to schools because schools are closed. Then we reduce the number of contacts at workplace to simulate telework, and so on. So and the other aspect is also that we can reduce contacts only for a specific age classes. So for example, we reduce the number of contacts for the seniors individuals in order to reproduce the effect of risk aversion that we knew from the data. So once we had all these ingredients to parameterize the model, the last ingredient that I want to present is the case testing and isolation. So how do we implement this aspect in the model? As you can see, there is no explicit compartment for that. So the testing and isolation of cases is actually implemented effectively by reducing the number of contacts in the contact matrix for a specific fraction according to the fraction of cases which is detected and therefore isolated. So this is the machinery that we build in order to predict the real number of cases. Now, how did we fit the model? So we used a maximum likelihood approach. The likelihood function accounts for a term including daily hospital admission data. So we fitted the model regionally on the daily number of admissions to hospital. And we fitted the model up from the beginning of the epidemic up to the end of June. Here, for the sake of visualization, I'm only showing you the exiting phase. And the other component of the likelihood function actually takes into account the number of detected cases taken from virological data, distinguishing between symptomatic and asymptomatic cases. With a maximum likelihood approach, we were able to estimate the target parameters, and that would be mainly the transmission rate and, most importantly, the detection rate. Now, after fitting the model, we validated the model on serological data, which became available during summer. And we saw that indeed the percentage of infected population predicted by the model was actually in line with the serological estimates, both at the national level, but also at the regional level. Moreover, we also performed a model selection analysis to actually prove that parameterizing contact metrics in order to account for changes in contact patterns due to restrictions and human behavior does actually lead to a better description of the epidemic trajectory with respect to using the same contact matrix for the whole period. Suggesting the importance of taking into account the human behavior inside the model. Now, moving to the results. What we found was indeed a striking underdetection. So here I'm showing you the number of cases predicted by the model, which was around 100,000 symptomatic infections. And compared with the number of symptomatic cases detected in the same study period, we found that only 1 out of 10 symptomatic infections were effectively identified by the system. The detection rate actually increased over time, both at the national level and also at the regional level, but suggesting that indeed capacity was increasing over time, but at the same time, the epidemic was decreasing. At the end of June, we found a large regional variation in the detection rate, but also we found that indeed, if we look at the incidence predicted at the regional level, the 2 regions in which the model predicted the highest incidence were indeed the regions in which the detection rate was among the lowest. So indeed, the testing system was not sufficient in detecting a large fraction of cases, especially in those regions in which the epidemic activity was larger. Now, in this slide, I'm only talking about symptomatic cases, but indeed in the model, we also have asymptomatic cases. So if we include asymptomatic cases, of course, the figure gets worse because the detection rate for asymptomatic infection was found to be less than half with respect to the symptomatic cases. And this leads to an overall detection rate that by the end of June did not exceed 30% at the national level. Now, besides quantifying this detection rate, what we wanted to do with this study was also to identify the weak links in this strategy in order to provide actionable improvements. So what we did is that we looked at participatory surveillance data collected from COVIDnet, which is a digital platform adapted from a previous platform, which included data from the flu. On this platform, a set of participants reports their symptoms over time. So this data provided an estimation of the suspect COVID-19 cases based on the symptoms reported by the participants of the platform. Besides that information, the platform also includes information on health-seeking behavior. So what we found is that indeed among the individuals with COVID-19 compatible symptoms, only 51% of them actually went to see a doctor. And of those going to the doctor, only a fraction of them got a prescription to get a test. So indeed, health-seeking behavior played a major role in the underdetection of cases. Now, what we found also is that if we extrapolate an estimate of the incidence of symptomatic cases from these data on participatory surveillance data, we find an estimate of incidence, which is the blue one in the plot here, which is actually compatible with the estimate from our model, suggesting that indeed the vast majority of suspected cases should be tested, which was not the, which was far from being reached in the situation after the end of the first lockdown. The French authorities wanted to test, to provide 700,000 tests per week, and this was not reached, so they tested only 250,000 tests. And of course, the weak aspects in these strategies were, on one side, communication to the general population. So it's important to increase awareness on the to the general public, and also access to the tests, which were at the time not efficient enough. Now, for the second part of this, we also wanted to tackle another question. So we wanted to find an indicator of performance of the testing system. So what we looked at was the detection rate as a function of the number of detected cases and the positivity rate. And the positivity rate is usually mentioned as an indicator of performance of the testing system. Now, in the study period, indeed, we had low positivity rates, but what we found is that the detection rate was not associated with the positivity rate. What we found instead was that the detection rate was indeed negatively associated with the incidence of symptomatic cases, which is expected. But the interesting thing is that indeed the detection rate was found to be a power law function of the incidence. So suggesting that detection capacity actually dramatically decreases for small increases of epidemic activity. This means that indeed testing capacity shall not increase proportionally to the increase of in incidence observed in the country, which was what happened during summer. But testing capacity shall be indeed improved faster and before the resurgence of cases. Now, for the last part of my talk, I will move to a different time period. I will talk about the beginning of 2021. So at the beginning of January, a first genomic survey found that among the detected cases, 3% of them were actually due to the UK variant, which was indeed at the time generating concerns about the COVID-19 spreading. Now, in this period, at the beginning of 2021, after exiting the lockdown, the French authorities implemented a curfew, which was at 8 p.m. by the end of 2020, and then was anticipated at the beginning of January. And besides curfew, recommendation on telework were given to the population. And actually, if you see again if you again look at the presence at workplaces, you can see that after the second lockdown and after the Christmas holidays, the presence of people at workplace raised again to the same level reached at the beginning of, at the end of the second lockdown. Now, how did we extend the model to study this particular time period? What we did is that we built a two-strain mathematical model. So we took into account, we included compartments for individuals getting infected with either the historical strain, the ones circulating during 2020, or the UK variant. We assumed cross-immunity between the two strains. And then we also included the possibility of getting vaccinated. So we added compartments for vaccinated individuals, and we included also parameters in order to model vaccine efficacy. So an individual with the vaccine is less likely to get infected, and if it gets infected, is actually less likely to transmit the disease and to develop severe symptoms. So now with this new model, we fitted the model to the data of to the hospital admission data in January. So we considered a transmission advantage of the UK variant around 60%. This was estimated from an independent study on French data collected from the first two genomic surveys in the country. And then we initialized the presence of the UK variant at the beginning of January in the model. And then we validated the model on the following data on the prevalence of the variant in the country. So this is the estimated variant frequency over time predicted by the model. We also looked at, in particular, the dominance date, so the date in which the variant accounts for more than 50 cases. Here I'm showing you the results for 3 different regions, so for at the national level in France and for other 2 regions in the country, including the region of Paris. So what we found was that indeed there was a heterogeneity in the estimated dominance date, and this was due to an heterogeneity in the penetration of the variant at the beginning of January. So the region of Paris was indeed the one in which the prevalence of the UK variant was found to be the highest. And then we also made a projection of the epidemic curve beyond the calibration period, assuming the condition estimated during the month of January when curfew was implemented. And the projection was indeed found to be consistent, in particular on the week in which we expected the number of hospitalization to actually exceed the level of the second wave, the level of the peak of the second wave for the region of Paris. Now, this here is the overall trajectory, so including both the historical strain and the variant strain. What we can do with the mathematical model is that we can decouple these two dynamics, and so we can see that the plateau found in the data in the month of January is actually explained by the model as the result of 2 opposing dynamics. So a decreasing dynamic of the historical strain, which is the dotted line here, with an estimated effective reproduction number below 1, around 0.9, and an increasing epidemic due to the circulation of the UK variant. Now, this increase, of course, was meant to lead to an increase, a large increase in the epidemic activity. Now, this large increase was indeed delayed, both due to the curfew, to the recommendation on telework during the month of January, and also due to school holidays in the region at the end of February. So the resurgence of cases was indeed delayed to March. And so with this, I would like to conclude and thank you for your attention. It's been a pleasure for me, and I'll be happy to take your questions if you have any. Thank you.
Thank you very much, Laura, for a very nice talk and also very well presented. And please, if there are questions, please raise your hand, and I hope to be able to see that or write down in the chat. But if you should be able to raise your hand. Well, while other people think about, I start with a question myself. When, in the first paper you talked about the proportion of infected that went into the various compartments, symptomatic, asymptomatic, is something that you took from our site data as fixed, or did you try to fit it?
We did not fit them directly. We took them from scientific literature, and indeed what we found was that what we did is that we parameterized the model over the last year, correcting for accounting for the available information that was provided by scientific works, but we did not fit them directly.
Okay, I see there is a question by Mattia. Please, Mattia.
So thank you, Laura, for your seminar. I have a question about the asymptomatic individuals. What about the distinction by age of asymptomatic? I mean, I don't see any distinction in what you presented. Do you think there is some influence of age structure on asymptomatic cases?
Okay, so indeed in the model, the percentage of asymptomatic cases is homogeneous among age classes, but indeed what is heterogeneous is the percentage of people developing pouchy symptomatic few symptoms. So basically what is included in the model is that children and teenagers do not enter the compartment of mild and severe cases, but can only stay asymptomatic or develop very few symptoms, according to scientific literature on the topic. So indeed, this is a detail that I didn't mention, but there is an age structure related to the difference in developing symptoms according to the age of individual.
Okay, but I mean, it's not clear to me whether it is a result of the model or a supposition from clinical data.
This is from clinical data. So what indeed is obtained from the data is that what the data suggests is that younger individuals are less likely to develop severe symptoms. So we included this aspect in the model, accounting percentage, different probability of developing severe symptoms according to the age. I hope this answers your question.
Okay, thank you, Laura.
Thank you.
Other questions? Well, maybe I have a sort. Okay, Marino, please.
Well, very nice presentation, Laura. Well, in the model with the UK variant, do you consider the different susceptibility at different ages? Because it looks like that now children are more susceptible.
So for the moment, we didn't include that information. The only difference in the historical strain compared to the UK variant in the moment in the model is the transmission advantage, so the transmission rate, and we also tested the an increase in the probability of getting severe symptoms, so requiring hospitalization, because data suggest a higher severity of the disease. So we also included that, but there is no distinction for the moment about the susceptibility due to the UK variant.
Yeah, because the you know, the big problem whether you should reopen the primary school or the high school and so on and so on. So
yes, so for that, indeed, there is a need to study, to look at studies performed in school settings. So indeed, this is a highly important topic, which requires a full study on its own.
Thank you.
Thank you.
Okay, maybe I try to ask, I mean, have more than a question concerning your talk, a general remark. I don't know if you try to make, maybe not scientifically, but at least look at some comparison between the epidemic in France and in Italy. Because something that strikes me that in general, it seems that there are more cases in France, or at least the ones that are diagnosed, but many more people died in Italy than in France comparatively. And I wonder if this is reflected in the level of his hospitalization. I don't know if you made any comparison, maybe just to the...
we did not make any comparison. Speaking about work, let's say, so scientific work. So I cannot provide you an answer scientifically. I guess that there are many factors that could affect this. This could be related to demography, to also to the human behavior. So as I told you, for example, in France, we found that indeed seniors were found to be more likely to respect social distancing. So there may be many differences hidden within this component, which may differentiate France from Italy. This is my take on this.
Thank you. Any other questions? Okay, if not, I thank you again, Laura, for a nice presentation. I thank you all the attendants for their presence here. And the next seminar is supposed to be actually in 3 weeks and should be by Andrea Bertozzi from UCLA. And maybe it depends whether we have still to fix the hour. So maybe it will be a little later than 5 o'clock, but we have to talk to her about that. And
2 weeks, Andrea.
What?
In 2 weeks.
2 weeks? I thought 3. I thought I have to check. My impression, I'll check the calendar. Well, you will see, you will read it. You can find everything on the web page of the
May 13 anyway.
Okay. So look at the page and you will all receive a message. And thanks again for your attendance.